Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. K. Suresh. Sir is MD, DIH, DF, FIAP, FIPHA, FISCD, family physician, public health consultant at Bangalore. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is uh, management of sore throat in general practice. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, dear friends. Thank you for joining this a very simple session. I am sure most of you might be wondering what is there a big thing. Yes, it is very common, but often we are over treating the patients with antibiotics when it is not required. So that's the major concern of the day. We'll just walk through some of the basics of sore throat. Now, basically, sore throat in the current era, 75 to 80% of the cases are due to viruses, not bacteria. When we were beginners in the medical practice, as you know, I am in the medical practice for about 56 years now. And second point, I want to make it very clear: the title of the today's talk is management, just not treatment. The difference being management includes what all needs to be done in that case for a primary care provider or what we call as a general practitioner. Identifying the need of referral comes first priority. We call danger signs. So find out if the referral is required urgently and then refer. If not, then you start treating. That is the basic difference when I use the word management or treatment. So as I told you, currently viruses are the major culprits. In the bacterial group, we have what is called as a group A streptococci, generally called as gas, and which is dangerous, used to be much dangerous about 20, 30 years ago in India because of the risk of acute rheumatic fever, arthritis and fever. Not that today it is not there, but the magnitude has come down drastically. Now, if we generally look at the what are the sore throat incidents and consequences as an individual, in India, an average child of under 5 years has about 3 to 5 episodes of acute upper respiratory infection, which is always involving throat. Therefore, either you may call it as pharyngitis, sometimes it may be only tonsillitis. Similarly, adults too have at least 1 to 2 such episodes. But most of the cases, as you know, do not seek treatment. When they seek treatment, probably it is already a time when intervention is required. They would have tried all possible home remedies before they come to you. But if we review the prescription of sore throat management across the country, we see that antibiotics comes as a first prescription, which is required in hardly about 1/4 of the cases. In addition to bacteria and viruses, of rate, of late, the environmental pollution, which is the particle of 2.5 millimeter or smaller, will create air in the air pollution are the highest risk of sore throat. And another reason which is becoming more common nowadays is what is called a subclinical hypothyroidism. There, the horse voice suddenly gets hoarse, so you may start suspecting sore throat. Another important change which has occurred in the last 3 years is prior to COVID 19 and influenza, that was in 2023 outbreaks, a general practitioner would have seen about 2 to 5 cases every week, or roughly about 2 to 5% of your total cases, more so in the winter. In the last 2 years, most of sore throat is symptom of respiratory infection, which are, as I told, mostly viral or environmental pollution. The major consequences of sore throat, repeated sore throat for children is low birth weight, preterm delivery, stillbirth, and this is when the mother is pregnant. If she has these things, which result into child being born with low birth weight, preterm delivery, stillbirth, etc. Poor quality of the air also results in anemia, cardiovascular risk. We also know that the air quality in India is deteriorating over the years. Between in 2021, it has proved that the association between intrauterine exposure to ambient particulate matter would result in all those consequences which I told. For simple purposes, definition when we say it's basically common word is sore throat, but technically you may call it pharyngitis or tonsillitis. And it is estimated that globally about 4 crore episodes occur every year. These are episodes where a patient sees the doctor. Without that, there may be double of that. Now, basically, this is the, as we all know, inflammation of pharynx, tonsils, adenoids, and lymphoid tissues around that area. I am using the word inflammation. Sometimes there could be an infection added, which is bacterial or viral. So children do come to you people very regularly, adults also, but much less. What is recurrent pharyngitis? There is a confusion between the words recurrent pharyngitis and chronic pharyngitis. First, let us look at recurrent pharyngitis, which basically means in the same season, if person has more than multiple episodes, then we call it recurrent pharyngitis. Chronic pharyngitis, which is an entity which is becoming more common these days. In fact, last week I saw one case. Yesterday also I saw another case in our own apartment complex, where because of the mismanagement, every time you treat, it is not fully treated. Therefore, the person develops some sort of antibiotic resistance and then keeps on getting episodes once in a year, twice a year, or more often, every 2, 3 months. Here, unlike the acute one, the symptoms here of mostly there is a complaint of painful swallowing action or feeling of scratchiness in the throat, maybe alternately burning sensation or piercing or stabbing pain. And sometimes this pain also worsens when the person tries to eat, or what we call it mastication, and during the process of swallowing and even talking. So sometimes the pain may radiate to the ears and temporomandibular joints, which aggravates the intensity. This sort of chronic pharyngitis is more common among adults, basically due to development of fewer antibodies after every infection and a less robust immune response to each infection. Etiology, we have already told, mostly it is these are viruses. They are listed as RSV, parainfluenza virus, SARS-CoV, human rhinoviruses, human metapneumoviruses, etc. In the chronic pharyngitis, again, these are viruses, but here, of late, smoking, environmental pollution, and allergic reactions are overtaking the infection in chronic conditions. Last year, most part of the country had this influenza virus H3N2, where sore throat used to be the major complaint. And the Indian Council of Medical Research has clearly indicated that most of these infections were due to this H3N2 virus. Because of the two outbreaks or epidemics I told you, certain changes have occurred in the transmission of viral sore throat. This susceptibility to viruses has reduced during the periods of pandemic, COVID-19 pandemic and influenza outbreak, basically because of the rampant treatment with antibiotic, corticosteroids, and anti-inflammatories. As you know, anything other than COVID-19 in the year 21 and 22 were less common because everybody was treated with some of these drugs which I told. We also know this year, that means last 1 year, from mid 23 to now, the sore throat due to other viruses are coming back basically for three reasons. One, the restriction which was there for congregation has been removed. Second, the respiratory etiquettes of using masks when you are in crowd, frequent washing of hands has already been relaxed. But now again, things are coming back. As I told you just last week, saw two cases. One important thing all of us need to know is acute sore throat is a clinical diagnosis. You all know we don't need big tests or anything. Simplest thing is characteristic clinical presentation reveal multiple raised, discrete, yellowish or white vesicular lesions with surrounding erythematic appearance commonly seen on the roof of the posterior aspect of the oral cavity. Sometimes, more so in the private sector, if people go to the ENT specialist, they may go in for certain tests, which are antigen antibody tests, sore throat, swab, culture, etc., etc. But when it is tonsillitis, you are very clear that the infection is on the tonsils, as you can see in the picture. So basically, one tries to do is to differentiate between the bacterial and viral causes of tonsillitis. If it is bacterial, the choice of antigen with antibiotics should be penicillin, which most practitioners today do not use, fearing the reaction. In other alternatively, you may be using ampicillin, erythromycin, etc. In terms of chronic tonsillitis, tuberculosis is implicated in these states. The other infection which might cause, which is coming up, we hear quite a bit nowadays, which is Pseudomonas aeruginosa. This is a chronic infection mimicking tuberculosis. So, if either tonsils or throat is affected, you may have chronic pharyngitis and tonsillitis. Now, basically, for though I said clinical examination is a criteria for most diagnoses, we use what is called as scoring, clinical scoring. There are three types of screening tests possible. Commonly used is the Centaur score. Here there are four items as you can see. Tonsillar exudate presence, cervical lymphadenopathy, history of temperature elevated above 38 degrees Celsius with no cough. So here what happens is we give 1 point each of the point, whereas in the subsequent one you can see there are 6 points and 5 points. For example, in if you use Makalasky score, here the first three things are common: tonsillar exudate, cervical lymphadenopathy, history of temperature, and cough. These are common, but they have added a criteria. If the patient's age is less than 15 years, you give 1 point. If it is more than 45, you give minus 1 point. Anything between 15 and 45, you don't add anything. There is a other classification which is also known as fever pain score. Here again, apart from the first three, that is elevated temperature, tonsillar exudate, and presenting to a physician within 3 days of the beginning of the symptoms, pronounced redness and swelling of the tonsil with no cough or rhinitis. So these are the criteria. In terms of using this, if the score is less 0 or 1, you don't need anything except symptomatic management. No further testing or antibiotics are required. For patients who score 2 to 3 points, rapid streptococcal testing or throat culture is an option. Nowadays, you have in the market ready-made kits. One can do this test, and within few minutes, you will be able to pinpoint. If the score is more than 4, then one must start immediate antibiotic treating along after taking a throat swab for testing. Recurring contact and chronic tonsillitis, as I told you, these are a specific phenomena for adults. As I told you, in the last 1 week, I have seen 2 cases. Basically, you don't see the throat typical infection signs of redness, etc. There will be mild streaks of pinkish coloration, or it may not be there. But major complaints is of while they swallow or talk, the hoarseness and the throat itchiness. In such cases, the best thing is after taking a swab, if required, start the antibiotic. And the preference of antibiotic, according to me, is penicillin. But nowadays, you see in the market availability of the penicillin, either oral or even injectable, has gone down so much that hardly 1 in 3 pharmacy people would keep it. Only the bigger ones, because the demand for these antibiotics has gone down. So penicillin G oral tablets, one can give about 400 mg tablet once a day, and if it is adult, twice a day for about 8 to 10 days. If it is a very repeated attacks, for example, the case I had last week had an annual repetition, and one penicillin LA12, long-acting penicillin of 1.2 million units, gives her a relief for 2 to 3 years. So you need to do, but only thing is, giving penicillin every time you'll have to do sensitive skin sensitive test and then give deep intramuscular. Since the Powder form has to be reconstituted, use larger quantity of water. Therefore, usually they supply 5 ml. And if with the standard protein penicillin, you may be diluting with 2 ml. But if you do that, pushing the drug becomes difficult. So, 2 points to keep in mind: use entire 4 or 5 ml of diluent. Number two, use a thick bore needle. You can use it 20 or 21 instead of 24, etc. So this is the case I was talking of, where I gave benzathine penicillin. This is, she had one such episode in 2020. One LA12 had given her relief until last week. That's almost about 4 years. So this is the best option, but maybe not from the clinical or practice point of view, but gives a better relief. Otherwise, penicillin G oral tablet, as I told you, Pentix is the commonest brand available, 400 ml tablets. Now, these are the risk factors for sore throat. The symptoms, as I told you, is basically indication of sore throat, scratching, pain, etc. There may be some enlarged tonsils, bad breath if it is a bacterial infection, and enlarged cervical lymph nodes. The risk factor is inadequate treatment comes first to my mind, because you know patients hardly take complete treatment you have given. The moment in 2 3 days time the infection goes down, the pain goes down, they may stop the drug. Or sometimes the quacks prescribe lower than the scheduled dose. Therefore, if there is a treatment, you have to give full course. There are also carriers of strep throat bacteria known. Either the person himself, sometimes a beggar, or a patient exposed to such a person might also get. And there is also a genetic predisposition of sore throat among people. Sometimes there is a pure immune response for people like who have a childhood infection or those who are on corticosteroid treatment. All these people have the risk of chronic sore throat. This is a latest working logarithm developed for approaching a chronic sore throat, which basically says what I have already said. If the sore throat is more than 12 weeks of duration, look at various symptoms, classify them properly, and manage according to the individual case. There is no standard protocol to manage. The basic differential diagnosis you may have to consider for chronic pharyngitis is gastroesophageal reflux disease, other infections, chronic, as I told you, mononucleosis, herpingiasia, diphtheria, epiglottitis, and pseudomonas infection. The airway obstruction may lead due to allergens. Of course, cancer and of head and neck may also cause that. There are three diagnostic tools you can use. One is a rapid test, which gives you around 75% sensitivity and 90% specificity. Combining rapid test with PCR may improve the result by another 10%. Culture and sensitivity has advantage because it has not only 100% efficiency, but it also gives you the antibiotic sensitivity. Therefore, in a case which does not respond to you within about 48 to 72 hours, in fact, you should take a sore tablet whenever you see it is a chronic case and then use the antibiotics. Rapid antigen tests, but one has to be careful. There are about 5 to 10% of false positive among children and more so among the adults. Therefore, PCR might increase the sensitivity, but the only problem is any of these tests do not distinguish between the bacterial, that is group A streptococcus, or carriers and viral pharyngitis. Both looks like semis. Therefore, the other biggest problem in our country, the availability of these tools is only in bigger cities, may not be available in all smaller towns. So one has to be very clear. Therefore, the basic challenges in differential diagnosis, particularly of bacterial versus viral, is basically it is a clinical judgment. All others become secondary. So one has to use the clinical and epidemiological features, clinical prediction scales, which we already talked of, and selectively diagnostic tools. The management or treatment includes first is identifying referral if required. Once you feel it is not a big problem, that means the person is not in urgent emergency case like breathlessness or total inability to swallow, etc., then you refer it to the ENT specialist. Otherwise, start with giving NSAIDs, that is non-steroidal aids like you can give them any of Brufen, Combiflam along with paracetamol. Then you can also advise them to do the gargling, saltwater gargling, plus lozenges. Nowadays there are so many lozenges in the market available. But the use of corticosteroid has to be careful, particularly if the person has more comorbidities like diabetes or any other thing which might harm their primary condition. So the title says symptomatic relief is the best option. Antibiotics does not help prevention of suppurative complications. Sore throat should not be treated with antibiotic to prevent the development of rheumatic fever because that doesn't help. And acute glomerulonephritis, particularly if there are risky patients. So what is the standard advice? First and the foremost is rest, oral fluids, salt water gargling are the main supportive measures for both viral and bacterial pharyngitis, tonsillitis, etc. Minimize the use of antibiotics unless you suspect it to be bacterial infection because of the clinical looking highly red, bright redness, etc. And convince the patient that the need of antibiotics is not there and it will be taken care with the palliative management. Penicillin therapy precaution, I have already told you. Basically, we give penicillin of 1.2 million units for adults, half of that for children. If the child is weighing less than 27 kg. The advantage of this long-acting penicillin is the drug is detectable at an effective concentration for at least 14 days. That means next 14 days minimum. And as I told you, in my case, one case lasted the effect for about almost 3 years. Not that antibiotic, but its effect. And the case yesterday I saw are on oral penicillin, and they started yesterday late in the evening. By now, the lady is comfortable. So injection giving penicillin, I already told, basically it has to be diluted more and given deep interval. If one should also know what is the pharmacokinetics of penicillin. This is the least soluble salt of penicillin G. Therefore, it provides a long duration action. The maximum concentration is observed between 12 hours and 48 hours. That means you know the effect of injection within next 12 hours they will start feeling comfort, and probably by 48 hours most of the infection is taken care. Therefore, a scientific study says that the half life, that means once you use the drug, it's about 336 hours. Whereas the routine penicillin, when you give, it is worth only about 7.7 hours. That means about 8 hours is what it is effective. So what does this penicillin do is it interferes with the synthesis of the bacterial cell wall called as peptidoglycan, and it inhibits the biosynthesis of cell wall, rendering the cell wall osmotically unstable. One of the studies in Kolkata has created, this is from a major hospital, of all patients who had chronic throat for more than 12 weeks, a history was taken and some investigations were also done. The incident was more among female, that is 1.25 times of more than male. About 39% of the patients were chronic smokers, 31% were addicted to alcohol, and only around 3% were reactive to HIV. Allergic, psychiatric illness, oral submucous fibrosis, etc. are some rare conditions. Based on this study is the flow chart which I had shown how a chronic case must be seen was developed. There is another study in Haryana. This is a community-based study. What they did is they, between the year 2012 and 14, 3,765 children under the age of 10 years were followed for 5,578 child years. That means some child might have come for 1 year, some might have come for 2 years, some might have dropped after 6 months. Basically, 3,765 children were followed by 5,578 child years. Here, about 1,069 episodes were reported among these people, which makes about 80% of cases, 8% cases, and the incidence of throat, the viral was 192 as against 60 episodes of bacterial, respectively, indicating that one-third of the sore throat in the community was also viral. Fever and running nose were the commonest symptoms of viral throat, whereas in bacterial it was more of throat pain, no rhinitis, etc. The clinical score of fever, running nose, and headache had an overall sensitivity of 86% and specificity of 6%. That means you can see clinically itself we can diagnose most of the cases, hardly 20% may need additional tests. So this is the management strategy of primary care. As I told you, these are summarized in the same guideline. For different countries have different guideline. Basic principles is there is to treat symptomatically and select cases only bacterial ones for antibiotic therapy. Our own national guidelines from the ENT Association from National, they say simple throat and tonsil examination in a beam life by general practitioner is what needs to be done. Refer to the specialist if it is severe, lasts for more than a week, or there is fever or swollen glands. Otorhinolaryngologists can do direct laryngoscopy for diagnostic purposes or taking biopsy. Throat swab you can also take. Because they are specifically trained, they may go into laryngoscopy. We will not get into that details. There are two primary tests. One is the rapid test. You can see the kits are available in the market. It hardly costs. It costs us about 20, 30 rupees. But it comes in the package of 25 and 50 units. So one can do the test and know whether it is streptococcal infection, then give the antibiotics, or else the last line in this comes in, give what is we call as antibiotic itself as a testing dose. Give an antibiotic. If it responds within next 24 hours, continue and complete the treatment. So, just to summarize, the systematic therapy is through NSAIDs and ibuprofen or naproxen, paracetamol, etc. Topical, basically lozenges, sprays, granules. Sometimes one may use anesthetics and antibiotic local applications if it is painful badly. And non-medicated lozenges, there are many strepsils, etc., etc. Most of you are doing and managing as per the principle, I hope. My only request to the people listening to me is please rationalize use of antibiotic. Thank you. Any questions are welcome. Yes, I'm holding.
Hi, sir. So, sir, we do have some questions,
Well,
and thank you for your wonderful presentation. So, sir,
thank
the first question from our audience is:
you. Mhm.
in case where antibiotics are indicated for sore throat, what factor should be considered when selecting the most appropriate antibiotic therapy?
Okay. There are two factors comes into picture. One is the clinical picture. Bacterial infections are so vigorous. As you can see in the present picture which is there, the tonsils and surrounding areas are brick red, very highly red. That is a clinical indication. And this identification becomes simple for the doctors as they get experienced. Instead of this, if there is a very pinkish, mild pinkish and all that, so that is number one. Number two is when in doubt, give an antibiotics. If you have the patience, penicillin is the best choice. If you don't want to take chance of reaction, then you can go to amoxicillin or erythromycin. But if it is a chronic, that means a person coming back and forth within a year, two times, three times, better to use long-acting penicillin.
Thank you so much, sir. The next question is: what are the key red flags or warning sign that suggest a sore throat may be indicative of a more serious condition require urgent attention?
As I told you, the first and most important is, which is common in diphtheria cases, where breathing becomes difficult. Second is swallowing or masticating becomes impossible, almost impossible. So breathlessness or dyspnea and deglutition or swallowing problem are the two indicators where a general practitioner should not take risk. And of course, if there is a swelling, sometimes people may come with swelling which is already under the chin, huge swelling. Those are the third one. But basically, the two top ones are breathlessness and inability to swallow even fluids.
Thank you, sir. So there's one last question.
Mhm.
What are some non-pharmacological measures that can be recommended to patient to alleviate symptoms of sore throat?
This I have already listed in these non-medicated items. First is salt water gargle. They can keep doing repeatedly. Number two, our home remedies also give mild antiseptic at home, that is turmeric. Turmeric is not for gargling, it is better put in warm milk, do a bit of gargling and then swallow. This is about 2 to 3 times a day. And sometimes, if it is a viral one, steam inhalation itself is a good reliever for sore throat pains. These are the three basic ones one need to do.
Sir, for answering all our questions. So, sir, that's all from our audience. And before concluding today's session, sir, any last remark from you?
Now, my last remark is in my last sentence. Use antibiotic carefully. Don't use for everybody because I find that 90% of the prescription, I'm in Bangalore now, 90% first thing comes is antibiotic. So there one has to be reducing this. Instead, if the infection, as I told you, if it's a very brick red infection, all that, cortisone use of injection dexamethasone is more useful than the antibiotics. Second is if antibiotic has to be used, use preferably penicillin. In India, streptococcus infections are still prevailing and they benefit a lot. I generally use this drug as first priority. Only in the first 48 hours, if the patient does not respond, I think of broad spectrum antibiotics.
Thank you so much, sir, once again for joining us today, sir. And
Thank,
with your permission, I would like to conclude today's session.
thank you. Thank you to all our friends for listening to me. Thank you.